Good evening and welcome to this another session of the Pearls of the Wisdom series. And I'm very happy to say that today we have a icon in stone disease, Dr. Marshal Stoller. The stone is global and its incidence is increasing. In last few years, we have an explosion of the technology where we've been treating stone very efficiently and clearing the stone. We have made some understanding of stone formation, but still we are far away from preventing the stone or doing the medical therapy. And Marshal Stoller has almost spent his lifetime working on a prevention. It will be a privilege to listen to him. You know, he is the professor and vice chair of the University of California, San Francisco, and to the urologist, he is not a new figure. And we had heard him the first time in 2004 when you came to India for the World Congress, and again you are here in JPAC, and you would definitely would like to listen to your concept of the stone formation. Welcome to JPAC, Mujibur Patel Urology Hospital, and I invite Dr. Marshal Stoller for his talk.
It's a great pleasure to be here with Dr. Desai and the whole group. As we look on this video, we think that we understand stone disease when we take out a ureteral stone or we do a percutaneous or open procedure, but we know that the recurrence rate is incredibly high. So for those of us who do a lot of stone surgery, we get busier and busier because you take care of the stone 15 years ago, there's a fix. So what are we doing about it? So what we've tried to do is we first try to understand that the Randall plaque is not the headwaters of stone disease. It's not the beginnings of stone disease. Rather, it is midstream, and there are things that are more proximal than the Randall plaque, and those should be the targets by which we should be aiming. In my 30 to 35 years as a urologist, we have had no new medications. It's the same stuff. We give diuretics, we give maybe some binders, we give allopurinol, but when you think about your careers, what new interventions do we have to prevent stone disease? So what do we have? We know there are 5 major types of stones, 85% of them being calcium-based stones, calcium oxalate, and we try to divide it, calcium oxalate monohydrate, dihydrate, and trihydrate. It may have implications only after the stone is taken out because we know that the dihydrate stone is easier to fracture than the monohydrate stones. We have the calcium phosphate stones. Based on urinary pH, those that have a pH less than 6.4 will make a brushite stones, and those with a pH greater than 7.4 will make an apatite stones, or a type of infection stones. The pure calcium phosphate stone is more commonly associated with primary hyperparathyroidism, albeit still relatively few people with stone disease have primary hyperparathyroidism. And a question to ask yourselves, why is it that only 10% of people who have primary hyperparathyroidism form stone disease? We know that increased parathyroid increases your serum calcium by resorption from the bone, increased absorption from the gut, everything increasing the calcium, but 90% of people never form stones who have primary hyperparathyroidism. That doesn't make sense. They should all make stones if it was exclusively based on your quantitative urinary calcium excretion. We have struvite stones, mainly in women. They always have a pH greater than 7.2. That's the only time that magnesium, ammonium, and phosphate will actually precipitate. So normal urinary pH is 5.8. We know that phosphate stones less than 6.4 will be brushite. Greater than 6.4 will be apatite. All struvite stones, all struvite stones will have a pH greater than 7.2. So just by using a dipstick, we know already quite a bit. What about uric acid stones? About 10% of stones are based on uric acid, and these consistently have a pH less than 5.5. Again, a way to differentiate that type of stone. And finally, cystine stones, a rare stone that has that hexagonal type of crystal that you'll see on a urinalysis, is pathognomonic for cystine stones, and typically they have also a low pH. But 85% of all stones are calcium based, and we can't differentiate the calcium oxalate from the calcium phosphate based on 24-hour urines, albeit we do 24-hour urines all the time. So here you can see a classic 24-hour urine that we do in America. And here you can see the four major things: calcium, oxalate, uric acid, and citrate, along with the pH. Those are, quote, the metabolic factors. And we look at the environmental factors, the total volume, the sodium or the salt in your diet, more common, a big problem in India with a lot of the salt. The sulfates and the phosphates, more associated with protein, animal protein intake, not as common in India. And then they put an equation together, the Eckel equation, that's 30 years old, may not be completely relevant, and you come up with a number. So you say, okay, you do these 24-hour urines, what does it tell you? It's inconvenient, but we do it. There's a very nice paper out of the Mayo Clinic looking at the rock nomogram just to see if you could predict secondary symptomatic stones. And if you read the paper very carefully, all of the data that they utilize to predict recurrent stones is based on history, talking to the patient. Has nothing to do with 24-hour urine. And the reason that the 24-hour urine was not incorporated in the nomogram is it does not help predict recurrent stones. So what do we have in 2017? We take a stone out. Colleagues like Dr. Desai took a specimen from the right and the left today to send it off for analysis. It may or may not help you, especially if you know the urine pH. And we do a 24-hour urine. What does that do? It doesn't help us predict whether or not you're going to get another stone. So what are we doing? The same thinking has been persistent for 30 years, my entire career in urology, and I'm tired of it. We need to look at a different way on stone disease. So when you look at a stone, this is a classic stone that we've got pulled from the kidney, and this is the dark stone here. This is the stuff that we see. This is sort of like the plug that goes into the papilla, and you can see they look completely different. But when we assess the stone, do we assess the black stone? Do we assess this plug? What part are we really looking for? And there has to be an interface, like everything, that there's an interface between tissue and the beginnings of stone in the papilla of the kidney, and there's an interface between this thumbtack in the papilla and the urine. The urine is very downstream in our understanding of stone disease, and we need to look at the precursors of what happens before you get this plug here, which is in the kidney. And this is where we are putting a lot of our energy. This is an early image that I did almost 20 years ago, trying to understand what it is when we look at a Randall plaque with the ureteroscope. We think it's just at the tip of the papilla, but maybe it's not. So what we did is we took 100 cadaveric kidneys and we put them in a mammography machine, because the mammogram looking at the breast is very good at looking at bile minerals, because that is a predictor of breast cancer. So we took the kidneys, we put them in a state-of-the-art mammogram, and this is what we see. And you can sort of see, here's the beginnings of the stone. All of these other aspects are the Randall plaques that we see with our ureteroscopes. But what's interesting is that when you look at the tip of the papilla, and this is what the Indianapolis group has said, they just looked at the tip of the papilla right here, and these are all the Randall plaques. But if you look carefully, we look at the papilla every day as urologists. But if you look very peripherally, what is this calcification doing way down here? And I challenge all of us that when we look at the papilla at the time of PERCs or ureteroscopy, look towards the fornix, and it seems like there is a distinct calcification or bile mineral that's different than the bile minerals at the tip or the Randall plaque. So when we take that mammogram of the papilla and we turn it sideways, looking at 90 degrees, you see there are these long serpiginous bile minerals. We're looking at the end of a nail, and all of a sudden now I've turned it 90 degrees. We've only looked at the tip of the nail. But what's happening is when you look at it sideways, and this is a 20-year-old radiograph that we looked at, and it was the first suggestion that in fact the randal plaque, we're just seeing the tip of it. But what's happening at the beginning is way up into the kidney that you can't see with an endoscope. You can't see even with nephroscopy. You can look at it carefully when you take a kidney out and bivalve it. And when you cut through it, you can even feel it with the knife to have a better idea. Which brings me to some of the classic pictures. And what we need to do as urologists is we need to have an interplay between nephrology, that's looking at the nephrons, and here are the nephrons here. You can see the loop of Henle. They talk about the loop of Henle, but when you see it, it has more meaning. You can see the glomeruli up here, and you can see this is the tip of the papilla. And then when you look at the, this is the papilla, this is the stone hanging off it. A vast majority of the bile mineral is in the papilla that we as urologists can't see, nor can the nephrologists appreciate it when they're looking at micropuncture techniques or they're thinking about nephrology. And here you can sort of see that the two different types of bile minerals. There's a proximal, way up high here, which is intratubular, that plugs the tubules. And then there's sort of a void midway through the papilla. And then down here, you see the interstitial, which is the randal plaque. There is a process that appears to be temporally related in terms of the pathogenesis of stones, and it gives us potential targets for intervention so that we don't have to rely on the 24-hour urine that does not do anything to predict who gets recurrent stones. And the type of stone really is irrelevant. It's an interesting finding, but doesn't really have any clinical relevance more than a urinary pH dipstick that will tell you the types of stones. This is the type of bile minerals that we're looking at in the proximal intratubule. I want you to look carefully at the crystals. They appear to be plate-like, like little plates that appear to plug the tubules. We always see intratubular obstruction even if we don't see the randal plaques, but we never see the randal plaques without the proximal intratubules obstruction. Let me say that again. You never see intratubular obstruction let me say it the other way. You never see randal plaques without intratubular obstruction. You always see intratubular obstruction when you see a randal plaque. So it appears that you first get the obstruction of the tubule, and there seems to be a pathophysiological cascade that we're now understanding a little better, and then you form the distal interstitial bile minerals, which are the randal plaques. So I want you to look carefully. This is the proximal intratubule, and when you look at the papilla near the tip, it looks completely different. They're small little spherules. They're calcified nanoparticles. A different process is happening. And I think I want you to appreciate that this is a consistent finding. We have now 80 papilla that we've looked at in conjunction with some of the papilla that we got here from Nadiad. So we're looking at that carefully. So as we try to understand these things, we're also trying to look at the bile mineralization. Now these are all calcium oxalate, 100% calcium oxalate stones based on traditional laboratory evaluation. We take the stones, we embed them in epoxy, we use a diamond saw to cut through them, we use a variety of different sanding devices to make a very smooth surface, and then we can look at a whole bunch of the actual formations of these stones. The second line is a 3D reformation from the computer, looking at what the stone looks like. And then we have cross sections, and here we have the different segmentations showing the different mineral densities of these stones. If you look carefully here on the third line, this is a calcium oxalate dihydrate stone, that the black area, just like the black that you would see on a CT scan, is voids. They're actually holes in stones. And that should not surprise urologists, because when you do your laser lithotripsy or you do a perk, all of a sudden it goes from hard, and then all of a sudden there's no stone, and you go to another area. The consistency of the mineral density of the stone is heterogeneous. And so it shouldn't surprise you that there are these voids within the kidney. We can then look at a similar fashion of representative calcium phosphate stones. The mineral densities are completely different, but again, you see this heterogeneity, and you also see these ring-like structures. It almost looks as if we're looking at a tree that's been cut, that there is a process which is happening in a temporal sequence. It sort of seems to have a rhythm, just like there's a rhythm with photosynthesis in plants. Here you can sort of see a combination of the mineral densities of calcium oxalate stones and calcium phosphate stones. And here you can sort of see the different mineral densities. This is mainly based about 600 milligrams per cubic cc. And here you can see that there's two peaks in the calcium phosphate crystals. When you look at the mineral densities, we realize that there is tremendous variability of the stone, and there's even more variability when we go within the papilla. So there is multiple processes that are happening here. It's not simple as saying it's a calcium oxalate stone. We need to segregate these stones in a more appropriate fashion. Now, everything that we do you think is new, but a lot of times they're not. And Alexander Randall, who was a president of the American Association of GU Surgeons that Dr. Desai and I are members of, I wish I had met him, but gave some very interesting data. He was looking at autopsy studies, and he looked at close to 1,200 autopsies, and just with his eyeballs, looking at the papilla, like you and I were looking at the papilla. We're looking at it with very sophisticated technology, and we're realizing that what Dr. Alexander Randall looked at was really, again, the tip of the iceberg, and this was in the 1930s. When we looked at these, we proposed the concept of just the basic concept of the papilla. There are three issues that make the papilla very susceptible to bowel mineralization. First, the kidney is an end artery. So that means that when the artery goes there to the glomerulus goes from the afferent arteriole to the efferent arteriole. The efferent arteriole turns into the vasa recta. The vasa recta have a descending vasa recta, and for every one descending vasa recta, there's 3 or 4 ascending vasa recta, and then they come back together and go to the renal vein. The further you get away from the glomerulus, the more hypoxic it is. And the tip of the papilla has a very hypoxic state. That's why in diabetics, you have papillary necrosis. And it's not surprising to urologists where you see part of the papilla necrosing. So it's relatively hypoxic. You have a second issue of the blood flow going through the glomerulus, going through the convoluted tubule, and Dr. Desai and I are going to talk later the next few days about why it's convoluted. We talk about convoluted tubule, but there must be a reason. And then you have laminar flow making a 180-degree turn into turbulent flow. And I want you to think about what happens at your house. Where do the tubes get plugged? They get plugged where there's turns. Where does atherosclerosis happen? It happens at the ostium of the renal artery. You see it where's the bifurcation of the aorta. You see it down near the iliacs and near the popliteal fossa. It's going from laminar flow, dividing into turbulent flow. So that's the second thing. The third thing is that we have the ability to concentrate our urine. And the way we do that is that the papilla is hyperosmolar, giving a gradient by which we can concentrate our urine. So the three basic things that we know from a simple urologist perspective: we have hypoxic conditions, we have laminar to turbulent flow, and we have hyperosmolality. It is no surprise that we all get these beginnings of Randall plaques and Randall plaques as you get older. The question is, why does it take so long? What is inhibiting this bowel mineralization process? And by understanding what prevents it will help us understand why certain people get these Randall plaques more. And I think all of us will appreciate that when we do uroscopy and you look at all these papilla and you see these massive Randall plaques, you know it's just a matter of time until the patient comes back. So we have to understand why these things happen. Why is it then that people with Randall plaques don't have pain. Right? You think that pain is due to obstruction. So looking at this correlative microscopy unit that I'm dealing with Dr. Sunita Ho at UCSF, this is a papilla that I want you to appreciate. All the white is bowel mineralization. And we're going to take a tour by actually going inside the tubules near the tip of the papilla. So pretend you're like going into a fantastic voyage and we're going into the tubules. You'll see that here the tubules are patent. So despite the fact that you have bowel mineralization all outside the papilla in the interstitium, the collecting ducts in the papilla near the tip remain patent. And that's why the vast majority of people with Randall plaques do not present with pain. So that's really a disadvantage to us as urologists, because by the time we see them, the Randall plaques have eroded in forms of stone, but the tubules, the collecting ducts, remain patent near the tip of the papilla. Let's see how we go to the next one. So now when we look at these papilla, we have hypothesized that the kidney is two aspects. There's urine, and for some people, like myself, when I cut into the kidney to do a partial nephrectomy, it bleeds. Now you tell me it doesn't bleed when you guys do it. For us, it bleeds even with the bulldog clamp on it. And you know it bleeds a lot. There's a lot of blood in the kidney, and there's a lot of urine in the kidney. We've put all of our energy into the urine. But I want you to look carefully on this picture. Unequivocally, you see the red blood cells here. That's from the vasorectum. Unequivocally, you see red blood cells up here. And where you see the bowel minerals, all the white stuff, appears to be, the majority is around the vasorectum. Most people have said that it's on the basement membrane of the loop of Henle, and I'll acknowledge that you find that. But I think equally important, or maybe even more important, that it appears to be a vascular impact. And that shouldn't surprise us. Most of the bowel mineralization that takes place in the bone is around the Habergian canals, around where the vascular supply is. When you think about the periodontal ligament, when you eat and you bite, let's say, on a kiwi fruit, the little white, the black seeds, you could feel when you actually bite on that kiwi seed. What stops you from biting harder is that every time you eat, your teeth actually move, and there's a ligament that attaches the tooth to the bone, and that's called the periodontal ligament, and it is centered around a vascular supply. And there's lots of other examples. With Tom Liu at UCSF, we're finding the exact same thing with Peyronie's plaque in the penis. And we can look at a variety of different bowel mineralizations, whether it be fibroids, bones, teeth, kidney stones. Mother Nature has some themes. And the theme with bowel mineralization is you need blood. And it's the blood that actually is causing the initiation of the bowel mineralization. And it should be no surprise to any of us that's what's happening in the kidney. Here's another picture, just showing a picture just last month in preparation for coming out here to visit Dr. Desai and the whole group. Again, you see the red blood cell, and here you see the calcified nanoparticles, the beginnings of the kidney stones, and it's chock full around this vasorectum. The blood is intimately associated with the beginnings of urinary stone disease. So, what starts the process? If we know what starts the process, we could stop the process. And I think, again, nature has themes, so we have to look at that. So here's some themes. It goes across multiple aspects. Here you can see on the bottom left is a geode. It seems like a whole bunch of different structures building on top of itself. And I want you to notice there's a void in the center. Just like in the kidney stones, there's a void in the center of calcium oxalate dihydrate stones. We could look at here that these are the same processes on a tortoise shell. It looks like a kidney stone. We can look here. This is a cross-section of some wood that Dr. Desai gave me when I was here last time. I cut that piece of wood that you gave me. Here is a seashell. Here is an onion. Here's another abalone shell. And I want you to ask yourself, I know there's not as many abalone as in California. why does an abalone shell stop growing? Actually, very interesting. There's a specific enzyme that gets secreted by the abalone that actually stops the shell from stopping to grow. We need to look at that and to understand that, how that can be applied to what stops stones from forming. Again, looking at other disciplines of understanding what starts and what stops the biomineralization process. I want you to look at all these patterns, and then I want you to look at this pattern. This is a kidney stone. It looks very similar to all the other structures. So it should not be surprising that the biomineralization that we see in a kidney stone has similar themes that we find in other structures in nature. We are not alone in forming kidney stones. And one of the processes in urology that's missing is creating animal models so that we can understand the temporal sequence by which stones form. So with Dr. Chi, Dr. Pankaj Kapahi, and myself, we developed a fruit fly model. And one of the advantages, I'm going to play this video while I speak. One of the advantages of a fruit fly is it's invertebrate. Everything that you see that's white are the kidney stones. They have two sets of Malpighian tubules that have 80% homology to the transporters that we find in our kidneys. Okay, and there have been more Nobel Prizes using the fruit fly than almost any other animal model. And even a simple person like me can do a knockout of a fly within a few months and look at a specific enzyme defect to be able to create a model. In this model, we did a defect looking at xanthine dehydrogenase. And there's a GAL4 system where you could specifically knock out specific enzymes in specific organs within the fly. It's an incredibly powerful system. And if you look here, this is the wild type. These are the Malpighian tubules that we can dissect out. This is the defect when we do an RNAi line on it. And you can see all the black stuff is the actual kidney stones in the fruit fly. And when you dissect these out, you can actually feel the stones between your fingers. And when you look at those early stones, you see these calcified nanoparticles that again look like that onion or that cross-section of a tree, just like we find in human kidney stones at the smallest level. It has given us tremendous insights into the pathophysiology of stones, and we're now in the process of looking at new mechanisms of actions of uric acid stones, and we're hopefully going to be submitting that to science soon, where it's some really basic understandings of how uric acid forms more than just looking at urinary pH. So we'll go to the next slide here. We've also looked at cat models, and this is a cat with a unipapillary kidney. And here you can see one papilla. This is a kidney stone right here. This is the stem. And if you look carefully, in this papilla, you see the beginnings of stone way deep inside. No different than what we find in the human kidney. So the question is, what else can we look on the cat model? In conjunction with the UC Davis Vet School, we then looked at the papilla of these cats. And as you see this video going around, you can see that the white or gray lumens in the papilla remain patent, just like in humans. And if you look at the interstitial, which is the blue in that area, that the blue is surrounding these patent gray tubules in a very similar fashion as we find with the Randall plaques in the human papilla. So again, a nice animal model to look at this. We can also look at that in humans, and we take out the papilla when we do our nephrectomies. And we can look at them very carefully. This is the kidney stone. This is the stem, and that goes into the papilla. So you can picture the papilla going around like this. We can then look at these images very carefully, and we find that the patent lumens, vast majority are 18 microns, which is the exact diameter of the vasorectum. Then we find smaller numbers that go with the larger tubes, and then we have the collecting ducts. So the tubes near the tip of the papilla are non-obstructive. The tubes in the proximal aspect of the papilla are the ones that are initiating this interstitial biomineral. Again, looking at that process, and again, looking at this picture, which I like to show, is that down here you see the stone, and then here's the stem, and here you see on the periphery of the papilla, that's where you have relative stasis. I want you to think about the Ganges River. Isn't there a Ganges River here you told me about? And I want you to think about the edges of the river versus the center where it's flowing. Where does the junk get accumulated? On the edges. And the reason that things accumulate at the edge of a river is because the flow is less. So think about the papilla. It's shaped like sort of this shape. There's going to be less flow around the outside than in the center, just like a river. And if we understand that, it should not be surprising that it's on the periphery of the papilla. That's where the initial intratubular obstruction occurs. Sorry, just trying to see what's going on here. So here, I want to show you this to get you in mind. We're now looking at the papilla in a different way. We take the papilla out of the human kidney. We then can stain the vascularity with iodine, just like you have the iodine with an IVP and something else, and it specifically stains the vascular system. We've confirmed that with CD31 and a variety of other antigens that are specific to the vascular endothelium from the uriniferous endothelium. And what I'm going to show you on this video, and this is the first time I've shown this video, is when we look at it, we can see the papilla. You get the picture like this. The white stuff is the vascularity of the papilla. And as we go and segment through this, you'll see that there is white and there is black. And as we do the cutting through here, the cross section, you'll see that the white dots are the vascular, the black dots is the urine tubules. And so we see the distribution of the vascularity and of the uriniferous aspect of the papilla. We also have the ability to be able to look at this papilla and actually look at the vascular and the nephron. Here you can sort of see we are segmenting out the individual nephron, and the individual nephron that is being surrounded by this papilla, and you can see the different color tells you the diameter. And now we're also looking at the blood flow within the different nephron, and it may be that certain people have a nephron distribution that may be unique that predispose them to stones. But we need to have the interplay between the urine tubules and the vascular tubules, and this technology allows us to do that. So when we think about the beginnings of kidney stone, we need to think about form and function. That's really the key to actually almost everything in medicine. So this is our concept. This is the papilla. It is not cylindrical, it's semi-elliptical. And that's what I want you to get. And as a result, there are the cortical nephrons, which are shorter, because by definition they can't go all the way to the tip because there is no tip. It's a papilla rather than a cylinder. You then have the juxtamedular nephron, which is longer, going towards the tip of the papilla, and you have the collecting duct. To simplify things, the flow is going through this papilla, and the end is the number of nephrons that you have. And we said before that there's a concentration gradient that goes to 1200 milliosmoles near the tip to about 320 milliosmoles that we find in our blood proximally. And we also have a pressure gradient. I want you to challenge yourself. Next time you do ureteroscopy, do you see urine coming out of the papilla? You see urine coming out the ureteral orifice, right? You see, how does the urine come out of the papilla? Is it a peristaltic wave? Is it the end of the vascular system and just slow? I just want you to sort of ask the basic question, how does urine come out of the papilla? And if we can maybe better understand that, it'll help us understand. And I'll talk about it later with you guys the next few days, how we think the urine actually comes out of the papilla. So now we could put some basic physics, and I don't want to get it too confusing. But I want you to think about this process. This is a schematic of a papilla. There is a long loop and a short loop. Again, the cortical nephron and the juxtamedullary nephron. And as it first starts, we are hypothesizing, I think we have a lot of data to support it, that the initial process is intratubular obstruction. And as a result, the functional radius of the papilla gets smaller and smaller and smallest. And assuming that the amount of blood going to the kidney is the same, it's just more fluid going through a narrower spot. What urologists understand is that when you get stiffness of the bladder, like a neurogenic bladder, and it's stiff, it doesn't work as well. But what's happening is that the compliance of the papilla gets less compliant because of the stiffness up high, and it's not unreasonable to think is that change in stiffness that's turning on the integrins and a whole bunch of other processes that turn on the bile mineral that is unique in the proximal intertubule and very unique in the interstitial aspect of the papilla. So this is our concept of what we want to think about. And this is what we think over time, we all have some intratubular obstruction, and it increases as we get older. And then we get the interstitial, which is down low, and then we get the bad stuff. And only at this stage do we actually see the randal plaques. We recently published a paper trying to get these points across. We divided the papilla into zones 1, 2, and 3, and we initially have, get my pointer, the intratubular obstruction, and then you get interstitial bile mineralization. And then these erode and form the stone. If we just think about the stone, we will not change our understanding of stone disease. We have to understand randal plaques, and more importantly, the precursors to randal plaques, to identify novel targets for the management of stones. So I want to leave you with 4 concepts. We need to be inspired. And how do we get inspired? We have to immerse ourselves in unusual environments. If we're not physicists, learn about physics. If we're not a dentist, learn about teeth. If you're not an orthopedist, learn about bones. If you don't do Peyronie's plaques, learn about the penis. If you don't know much about the uterus, think about fibroids. If you think about diabetes, think about the vas deferens. All of these aspects are minerals, and I believe all the processes have common themes. Second, by looking at these different variety of bile minerals, it is up to us who see this clinically every day to synthesize new ideas. So you want to look at patterns, just like the patterns of the onion and the wood and the seashell and the kidney stones. There are patterns, and if we can identify themes, we can understand what is a little different about the kidney versus the penis with the Peyronie's plaque. Then we need to experiment. We experimented today. We had an idea about new ways of dealing with kidney stones, and we said, hey, let's try to sort of make a little change and maybe it has better application than something else. We don't know. We have to try new things. And finally, once you've had those new ideas, we have to refine them. Do you decrease the temperature? Do we need to put a color to them? But by doing all these things, you need the inspiration, the synthesis for the patterns, the ideation, their experimentation, and the refinement. That's what's going to make a difference in our clinical practices, and it's going to make a big impact on people where 1 out of 10 of Americans will ultimately form a kidney stone, and that, 30 million people, that's a small number for India, they will have a 50% recurrence. So we could be operating every day for the rest of our lives. We will not solve the problem. We will decrease sort of pain and anguish, but we won't stop the disease. I think by understanding the bigger picture, we'll be able to make those changes. Lots of data out there, and it's readily available. Let's look at that data. And I'm going to be collaborating with everybody here in Naviad about some new big data bases. And again, I would make the comment that bile mineralization has themes. We need to understand the relationships. We need to understand collaborations with people outside of urology. And then, instead of reading your novels at night, which I still do, okay? We need to read papers that are outside of our comfort zone. We need to look at review articles that are looking at bones, looking at vascular disease, looking at Peyronie's plaques if you don't look at them, looking at teeth. I never thought I would learn so much about tooth. It's fascinating, and as a result, I'm doing a lot of collaboration with Sunita Ho in the School of Dentistry, and it's really taken me to another level by creating these relationships, both at the School of Dentistry, looking at chemistry departments, material science departments, at Caltech with the chemistry departments, and looking at all these different people. As long as you have an idea, you can apply your thinking and your problem to other people's aspects, I think we'll be able to come up with some new ideas. I want to acknowledge that the National Institutes of Health has allowed me to have 3 grants, allowed Sunita Ho to have a grant, that's really put a lot of this stuff together with our correlative microscopy team, and I invite any of you to come to sort of see what we're doing, where we can look at basic histology, look at scanning, electron microscopy, look at EDX, and have the ability of the computing power in Silicon Valley to make big differences in our understanding of stones. I want to thank Dr. Desai and the whole group here for giving me the opportunity to be able to speak to this wide audience through this webcast, and I hopefully have inspired you to be able to think about stones in a different way than being stuck in the old dogma of stone analysis and 24-hour urines. And with that, I hope that we'll come up with new ideas and new therapies as we move forward in our understanding and treatment and prevention of urinary stones. Dr. Desai and the whole audience, thank you very much.
Thank you very much for that very inspiring talk. Certainly it was really stimulating. The stone formation, stone analysis, and the etiology of stone is the very, very complex theory, not much understood, but you have made it very interesting, and I'm sure all across the globe and all across the country, people who have heard there must have got stimulated to do some work in stone analysis, stone etiology, and stone formation. Well, these are all pearls of wisdom which we wanted to hear from you. And on behalf of JPAC and Mujibhai Patel Urology Hospital, I am extremely thankful to you for giving us this pulse of wisdom and this series of pulse of wisdom. Thank you very much once again. Thank you.